At 7 o'clock, we could get started. Hi, I'm Al Musella, and this is our Brain Tumor Awareness Month webinar series. Our special guest host tonight is Dr. David Ashley, who's the director of the Preston Robert Tisch Brain Tumor Center at Duke. Dr. Ashley?
Well, thanks, Al. I think, am I the host or you're the host, I think?
You're the host. You're the host.
And I'd like to thank Al for the invitation and also thank him for all the wonderful work that I've become aware of since I've been here in the United States. You can hear from my accent that I'm from far shores. Now, just let me, that should go, oh, there we are. I beg your pardon. Here we go. So I thought what I'd do is just give one or two slides of background so the folk on the webinar understand who I am and can contextualize where I'm coming from. I was actually trained in the United States way back in the 90s and then went back to Australia and ran several programs. More recently, I've been in the United States for about 2 years and the director at the Brain Tumor Center for 12 months. The Brain Tumor Center at Duke was established more than 80 years ago, and it's certainly one of the world's leaders, particularly in immunotherapy. We see a large number of patients with malignant glioma, certainly the largest in North America and probably one of the largest centers in the world. And we see patients from really all over the United States and internationally. So that's me. What I'm going to do tonight is to talk about how we've gone about targeting the immune system in glioblastoma and some recent breakthroughs that we think we're starting to see. I'm going to talk about immune responses to tumours in general, some of the barriers that we faced in brain tumours in particular, but recent notable successes. In that setting, I'm going to talk about how we're really starting to wake up some elements of the primitive immune system through our work with the polio virus, and then some of the confounding questions about these evasive and evolving tumours that we need to overcome. And then I'll stop and offer everyone a chance to have a chat. So I think really, at least in my world in cancer, you would have to have been living under a rock for the last decade or two not to be aware that immunotherapy has become very mainstream and is really big news and starting to cure quite a substantial number of patients with a variety of different cancers. This is not quite true. Immunotherapy does have some side effects. We won't talk about that tonight, but clearly, if you target the immune system, one thing you have to be aware of is that there's a chance that you can target people's normal bodies as well. And really, the story started with the discovery that some of our immune-fighting cells, T cells and B cells, are really kept at bay or suppressed through these switches called checkpoint inhibitors, or checkpoint proteins rather, and that by creating inhibitors to these signaling pathways that you can awaken some of the T cells and other cells and really start to see responses in tumours. And I'm going to talk a little bit about that. But the difficulty has been that whilst there's been a lot of excitement in illnesses like melanoma, colorectal cancer, some other types of skin cancer, these very promising therapies have really not translated meaningfully in the setting of brain tumours. And this is just some data. The details are perhaps less important than the message, and that is that using checkpoint inhibitors really hasn't seen a great deal of benefit to date above and beyond other drugs that have been used to try and help people at the time of recurrence or even in the newly diagnosed setting with high-grade malignant gliomas. But immunotherapy is not all about checkpoint inhibition. It's not just one thing. And there are a variety of approaches that we're now seeing coming into clinical trials that are very exciting and offer us new avenues to awaken the immune system. And I've just listed a few here that have already received FDA approval in a variety of different cancers. So not in high-grade brain tumours as yet, but we're seeing viruses, cancer vaccines, and other things, other types of therapies that are receiving approval, and we're seeing activity. So there's really, what I want to do is go back to basics and talk about the bits of the immune system that we have to wake up and we have to get activated in terms of fighting cancer. And fundamentally, there's two parts to our immune system. There's a very primitive part called the innate immune system. And this is a very non-specific part of our immune system as a mammal that responds to danger signals such as viruses, bacteria, and tumours. And it's made up of cells that will see these danger signals and react and try and kill cells that contain them. And these cells are neutrophils, macrophages, other cells called NK cells. Once an innate signal is underway for any reason, the innate immune system then talks to what's known as the adaptive immune system. This part of our immune system is less primitive on an evolutionary basis and deals with identified targets. So these are T cell and B cell responses. And I guess the most common example of this that people are aware of is vaccines. So if we vaccinate someone for polio, for example, or tetanus, it's a B cell response, initially a T and then a B cell response and an adaptive immune response. In the context of anti-tumor immunity, the issue is we have to orchestrate these two things. So what needs to happen is many tumors are what we call cold. They have no immune inflammation. They're invisible to the immune system. And we somehow have to firstly wake up the innate immune response and make the tumors into hot tumors. And I'll show you an example of that as we go through this talk. Once the tumors are hot, they can then be recognized by the adaptive immune system, and the adaptive immune system can respond. If the adaptive immune system only sees a cold tumor, it's completely invisible. And there is no way that the adaptive immune system can react to a cold tumor. And I'll show you this. So for example, we know many melanoma, before we've even treated them, are hot tumors. And this is an example. You can see the pink reddish color cells. They're T cells in a hot tumor, ready to be treated by an adaptive immune response. Whereas to your right, you can see glioma is a completely cold tumor, universally very few T cells and not ready to be treated by an adaptive immune response. And this has now been very well characterized in many cancers. This was a beautiful paper that was published in 2018 that looked at large numbers of tumors with lots of different methods and was able to identify different types of immune landscapes in different cancers. The point of all this is, if we come down here to glioblastoma here and low-grade gliomas here, what you can see is the vast majority of these tumors are either what's called lymphocyte deplete or immunologically quiet. So they just don't have the resting state where the innate immune system has been woken up and is able to talk to the adaptive immune system. So let's put that aside for a moment and let's talk about immune privilege. and the brain. People talk about, well, the brain is a very special case. And yes, this is a major issue, and the immune environment and responses in the brain differ. And that in part may explain why glioblastoma, for example, is a cold tumour. And there's multiple reasons for this. There's different types of regulatory T cells, the structure of the brain, some of the proteins in the brain are different to the rest of the body. And what the reason for this is we can't afford much inflammation in our normal brain in order for it to function. It's just far too important. So the brain has mechanisms to control the inflammation. It's not a no-go zone completely, and we see inflammation and multiple sclerosis, for example, or meningitis, illnesses where the inflammation in the brain has gone too far. So immune cells do get in, but there is privilege in the brain. And the privilege and the different immune responses can be illustrated in terms of anti-cancer therapy, where if we look here, this is metastatic melanoma to the brain and treated with immune therapies. These are response rates, and what you can see is the intracranial tumour continues to grow while the patient responds outside the brain, telling us that there's a difference in the immune response between outside and inside the brain. So what about glioma immunotherapy? In that context, what we see is a series of barriers to the innate immune response, and therefore talking to the adaptive immune responses in the brain. And these are things like low white cell counts, different ways the cells traffic and move through the brain, etc. And there are a variety of strategies to overcome each of these things that we're now starting to take up and move through in a systematic manner. So these are all, the checks there are all current preclinical or clinical trials that we have in play at Duke, addressing all of these barriers, both in innate and adaptive immunity. Despite all those barriers, we know through early successes that we can get an immune response in glioblastoma, but it's in very special circumstances. So this is examples of two different children who have a very rare form of glioblastoma that has multiple mutations, much more like melanoma. And this is with treatment with checkpoint inhibitors. And one can see that in the right setting with a hot glioblastoma, which I have to emphasize is a very, very rare situation, you can get responses to checkpoint inhibitors. But the vast majority of glioblastomas are not hypermutant at diagnosis, and this type of response just doesn't happen. So how can you wake up the innate immune system? And what we've done, and my colleagues Matthias Gromeyer and Daryl Bigner have been working for the past 2 decades on modifying the polio virus. Polio virus is a very potent stimulus and a very an excellent way of awakening the innate immune system. But obviously the polio virus is a scourge to humanity and actually hurts the brain. So what Matthias did, and I still can't get to the bottom of why he chose to do it, but he chose to take a scourge of humanity, modify it with the common cold virus, and create a new virus that still had the effect of awakening the innate immune system and yet would not cause the damage that the polio virus in its native form would cause. So we were able to take this virus, and we were able, in an early phase study, to treat a number of patients, and here's the way it works. The virus is instilled through catheters into the brain tumor tissue of the patient and released. It's taken up and it causes the release of danger signals from the tumors and then this profound innate response, monocytes, macrophages. These are all cells of the innate immune system, and they in turn ultimately talk to the T cells, the adaptive immune system, and we have a vaccine effect ultimately to the tumour from the combination of the polio virus and the tumour breaking down and sending danger signals to the innate immune system. So we were able to treat in the first study just over 60 patients between 2012 and 2017, and we published this work last year in the New England Journal. And what you can see is that we think we've got a number of long-term responders. These are now patients. These are people with glioblastoma that's resistant to all other forms of therapy. And in our hands, this is a fatal illness. The red here are our historical records of patients who've not received the polio virus. And this is the outcome of the 61 patients who received this installation of the polio virus directly into the brain tumour. And we now have a number of patients who are actually out 6 and 7 years from the time of their first treatment, and they're alive and well with no evidence of disease. These are some of the scans from those patients. What happens is this is before the installation of the polio, after the infusion of the polio, and initially these tumours get a little bit worse and there's inflammation, and then they start to shrink, but the changes happen over a long period of time, sometimes 6 to 12 months. Here's another patient just prior to polio. You can see that the tumour looks a little bit worse about a month later, and then about 3 or 4 months later the tumour starts to shrink. This is an example of one where the tumour really started to shrink almost immediately, but there was some inflammation. This dark area is inflammation, and ultimately over the period of 6 to 12 months the tumour looks a lot better. So we learned from the first study that we can do this, it's safe, it's tolerable. We think it increases survival. Certainly we're seeing a number of long-term survivors. We've actually identified now some gene markers that we're very excited about that tell us more about who will and won't respond. And we've moved into the next study, which is called a phase 2 study. We're doing this in 3 institutions at the moment. At Duke, we've also opened it at UCSF and Mass General up in Boston to try and replicate those results that we've seen in our first study and make sure that other people are able to do the same thing that we can. And we're also treating patients with melanoma. We've just had some very exciting early results in melanoma and very high-risk breast cancers. So we think that what's going on is we're converting a cold tumour into a hot tumour, and now we think that we may be able to combine the polio virus with other types of drugs that actually enhance the adaptive immune response, such as the checkpoint inhibitors. So by creating a hot tumour, it becomes very rational to then start to wake up the adaptive immune system as a second step. So I'm going to just change stream now. This is a very complicated slide, but it illustrates a point. And I'm going to talk about this confounding question of evasion and evolution. What we and others have shown is that these glioblastomas are quite mischievous in that, and probably this panel here is the best panel to look at. You start with a tumour and there is what's called tumour heterogeneity. So one tumour actually has multiple what we call subclones, so the yellow, blue, red and white representing subclones. And as the tumour grows, it develops new subclones that are actually now different and have a different profile, still within the tumour mass. These are individual cells, different cells within the tumour mass. And as the tumour grows, it grows different clones or different cells. what happens is when we treat that tumor with something like radiation or temozolomide, we kill off the sensitive cells. And in this case, we're killing off the yellow cells and to a great extent the red cells. But what we're left with is the resistant cells. This is called selective pressure. And we've done modeling around this. And the problem is that all of our narrowly based immunotherapies like vaccines or other approaches against very narrow targets leads to this selective pressure, and we've demonstrated this. And these types of data tell us that there's constant evolution of these tumours, and a narrow single target only hitting the blue or the white cells is very unlikely to lead to durable responses in patients. And so when we come to the adaptive immune system, this is the system that sees and targets specific targets, we really need a very broad-based approach with multiple targets. And this is an example of a study that was done at Duke where we looked at it, this is historical now, but we looked at a very narrow target, one target, the epidermal growth factor receptor. And what you can see is that this is a stain, the brown cells have the target, and then when the tumor comes back, the target's completely gone because the cells that had the target are wiped out, but the clones that don't have the target continue to prosper and the tumor just marches on its merry way. So we have to have a very broad-based approach to adaptive immunity. And what we've done at Duke is we've exploited the fact that we think that many glioma have evidence of viruses that they carry across the majority of tumor cells. And this is just a slide that shows you some of that tells us that these virus proteins, and in this case it's CMV, which is a very common virus in humans, up to 60% of people carry this virus, is seen in these brain tumor cells in the majority of cases, and we can develop an immune response to these viral particles within the tumor cell. John Sampson and his group several years ago developed a vaccination strategy that was targeting these viral proteins in the glioblastoma, and were able to perform that in people with recurrent disease, I beg your pardon, with newly diagnosed disease, and have really shown excellent early results. And in this case, if you look at this upper right panel here, this is one of John's studies in people who have newly diagnosed glioblastoma. And what you can see is that the patients who received a vaccine that did not have the CMV in it did more or less the same as what we would normally expect in glioblastoma. But patients who received the vaccine with the CMV protein had a survival over a long period of time of nearly 50%, which was really outstanding. And we've now treated about 30 patients in this fashion, and the results do seem to be holding up. And so we've just opened another study, and we'll be opening a third study later this year that will treat a larger number of patients to see if we can replicate these early results and try and help more patients. So these are very promising early results. We're now duplicating them and moving it into this larger so-called phase 2 format. And another thing that we're doing and has been done up at Boston and in Europe now is this so-called neoantigen approach. So in this approach, through tumor sequencing, we're able to identify multiple targets in every individual patient. And by taking those multiple targets, we can develop a vaccine to more than just one narrow target, but 10 to 20 different targets in a personalized vaccine. And the early results in melanoma look quite promising, and it looks like, at least proof of principle, we're able to develop immune responses to multiple targets in patients with glioblastoma. And we hope to start some of these studies probably mid next year at Duke. I'm going to stop. I just want to acknowledge all the folk who are involved in some of these studies. This is our senior leadership team at Duke. John Sampson's work I talked about, he's the chair of neurosurgery. Obviously, Daryl Bigner and Matthias Gromier, along with Henry and Alan, ran much of the polio trials. And Nick Gizardin is the our clinical research director. Peter Fecci is doing outstanding work on some of the immune privilege that we see in glioblastoma, and Haiyan is an outstanding molecular biologist who's identified many of the genes. Susan's our clinical research manager. So these are our outstanding staff at the Brain Tumor Centre at Duke. And I think, Al, I'm going to stop there. I hope it was I know it was a whirlwind.
Oh, that was perfect. Thank you.
And I'm happy to take any questions.
Okay, we have a few questions. First, could you define what a neoantigen is? What does that term mean?
Can you hear me okay?
Now I can. Repeat it. What is a neoantigen? Can you hear me?
Yeah, sorry.
Okay.
I beg your pardon. I had it on silent.
Oh, let me ask the question again. What does neoantigen mean?
Oh, yeah, sorry. So neoantigen is a term for an antigen that doesn't appear in the normal person. So it's a target. What happens is when you get mutations in a tumor, they still make proteins. They still make the mutated gene still tries to make a protein, but the protein has an abnormal sequence. So it appears as what's called a neoantigen and can be targeted by T cells if you can wake up the T cells with a vaccine.
On average, how many neoantigens would a tumor have? Is it like 3, 5, 10, or 1,000?
No. So one of the problems with glioblastoma I didn't elucidate in this talk is that it has a very low number, relative to, say, melanoma, has a very low number of mutations. So on average, we see about somewhere between 40 and 80 what's called somatic mutations in glioblastoma. Of those, somewhere around 20 probably are targetable. And of that 20, somewhere between 5 and 10 you can actually generate an immune response to. So not many.
Okay. So would you think you would have to target all of them to completely eradicate a tumor, or if you do half of them, that would be enough?
Yeah, look, it's a great question. We don't know is the short answer. We think that they're by targeting neoantigens, we also may be able to break tolerance to some of the normal proteins as well. I think it's, you could probably, what we hope is that we get spread of the immune system to cells that perhaps don't even contain some of those antigens, because we could make the tumor hotter.
Okay. With the polio treatment, is that just a one-time shot?
Yeah, it's a one-time shot, but we've now had 5 patients who we have retreated about anywhere between about 4 years and 6 years later, just off the top of my head. So it appears a little bit like having a vaccine and then a booster. So for example, we all get tetanus shots every, 4 to 6 years or something. It may well be the same with the polio, in that we may need to give some patients boosters. And we're just sorting through this. Of the patients that we've retreated with the polio virus, the response rate seems to be about 2/3 of them ultimately re-respond to the polio virus again.
Okay. And you mentioned that there's a set of markers that might influence if the treatment works or not. Are you at liberty to say which markers?
Yeah, sure. So we actually presented this at the Society of Neuro-Oncology meeting, so it's in the public domain. But it's actually really interesting because in melanoma and other tumours that respond to so-called checkpoint inhibitors, a high mutational burden portends for a good response. In glioblastoma, the response to poliovirus seems to be in low mutational burden patients, actually the very situation we want. So we're sorting through this. We had, in the first study with the poliovirus, we were able to get enough material from about 30 patients to start to do this analysis. We need to replicate it in the phase 2 study, and we're just going through that exercise at the moment. So we'll be more confident about those results in a year or two.
Okay. How many patients had the polio treatment so far?
About 120.
Oh, good. Okay, we have a couple more questions here. Are any of these approaches available for newly diagnosed anaplastic astrocytoma, or are they just glioblastoma?
So at the moment, it's glioblastoma and it's not newly diagnosed. We are in the process of writing a newly diagnosed study, and we hope to open that we really hope to open it in the next few months. The anaplastics at the moment are not eligible, and we only have data in glioblastoma. But it's a good question. We've written a study for grade 2 and grade 3, and we need to get to that, but we've got to get funding and so forth to support it.
How about pediatrics?
So we've opened the study in pediatrics. We've treated our third patient. The FDA, rightly so, required us to start with older kids, 12 to 16, and older. So children with glioblastoma, the tumours are often more deep and midline. And so it has been a difficult study to accrue to because we had to start with tumours that were very peripheral to be safe. And that's a much rarer situation in paediatrics. So it's been slow. We've treated 3 patients. We need to treat 6, and then we can start to expand to younger kids as well.
Okay. What would the ideal patient be for the polio treatment? Somebody with a large amount of tumor or a small amount of tumor?
Small.
Small.
Yeah. What we've shown is the responses are better. So you need tumor. You can't have no tumor. We think that it's important that you have some tumor, but we think that there's a point where it becomes overwhelming. So we limit the enrollment to patients who have tumours less than 4.5 centimetres in greatest diameter.
That could be after a surgery, right? Like if you have a large tumor and you've resected and you're left with 1 centimetre, you're okay?
You're okay.
Okay.
Yeah. And in fact, in the newly diagnosed study, what we're building is a proposal that would be, really paradigm shifting. Really, this is where we would probably. So conventionally in glioblastoma, you always go for a complete resection because there's evidence that patients who've had complete resection have a better outcome. But what we think we want to try and do is actually deliberately do an incomplete resection but leave a very tiny amount of tumour, maybe a centimetre, so that we can anchor the catheter, get a response, and then about 4 weeks later go back in and complete the resection.
Oh, that's interesting.
Yeah.
Okay. Todd Smith asks, they have a son who's 24 years old with a secondary GBM. He's been going on for a couple of years now, and he's never gotten sick until recently. And his doctor was saying by getting sick with like a GI bug, it shows that his immune system is working. Do people with the glioblastoma usually have a depressed immune system for every other disease too, or just locally in the brain?
No, so so even before we give our patients any medicine for glioblastoma, they have low immune systems and they are at risk of opportunistic infections. And this is well reported. In fact, about a third of patients with glioblastoma have immune systems equivalent to AIDS. before we've even given them any medicine. Chemotherapy compounds that problem by also causing immune suppression. So for your 23-year-old son, if he's had chemo and he's got a glioblastoma, he's got 2 reasons to be immune suppressed, and he is at risk of other infections.
So would it be a good indication that he has like a fever of 102? That means his body is fighting it, or that's bad that he got the infection in the first place?
No, fever is a very primitive response to infection, and you can, even in patients who have completely wiped out immune systems will get fever in response to an infection. So it doesn't mean he's fighting it well. You need to see your physician and get that sorted out.
Okay. Somebody asked, that slide that you had with the results from the polio, that was recurrent glioblastoma, correct?
Correct.
Okay. And somebody asked, why would you be adding CCNU to the polio vaccine if the CCNU is going to kill your immune system?
Yeah, well, so when we started treating patients whose tumours were coming back after the polio virus, and Nick Desjardins noticed there were 2 patients that after 1 single dose of CCNU had dramatic responses. And when we looked at the patient's makeup of their T cells, we saw that after a single dose of CCNU, that the immune makeup of the patient was recovering in a very interesting way. And so we had hypothesized that a single dose, not an ongoing course of CCNU, but a single dose could modify the immune system, and in recovery from a single dose of CCNU that may aid or benefit the polio response. In fact, we've now, that slide's a little bit old and I should take it out. We've completed that study, and that was wrong. So we tested that hypothesis and it didn't work. The patients who received a single dose of CCNU actually didn't do any better than the patients who did not. So right now we're back to just treating recurrent glioblastoma with the polio virus alone. And we are, as I said, hoping to open a newly diagnosed study in the not too distant future.
Have you used the checkpoint inhibitors with the polio virus vaccine yet?
We have in 1 single patient where in setting up for the newly diagnosed study, we wrote some individual patient protocols, and we use the checkpoint inhibitor in 1 single patient. We haven't used it routinely in other patients. We did several of us did the nivolumab and ipilimumab studies in glioblastoma. These drugs do cause some swelling in the brain, and then polio causes swelling in the brain. So we will be using checkpoint inhibitors, but we need to do it judiciously and very carefully so that we don't cause more problems.
Okay. If you inject the polio virus once, wouldn't your body develop an immune response to it the same as if you gave a vaccine, so that when you did it again a few months later, like you said, in a few patients, wouldn't the body just destroy the vaccine, the virus?
That's why we have to give it into the brain. So the viruses are cleared by antibody on the whole, a little bit of T cells as well, but we can get enough virus into the brain that is not cleared by the immune system in order to trigger the innate response before it's cleared. When we actually give a polio booster to our patients prior to them getting the infusion in the brain, quite deliberately, because we don't want virus out in the periphery. We don't want virus in the GI tract or in the body elsewhere. And in fact, we've checked for virus in our patients in the periphery, and we can't detect it. But we think that both in the animals and in the humans, there's enough virus in the brain to at least initiate the innate immune response before it's cleared.
Okay. Do you have any plans to expand these studies to other centers?
Yes, we already are. So I think I
I know
mentioned,
you mentioned it too, but like we
yeah,
have somebody in Seattle who wants it. Um,
yeah, we can't.
it's
So
not,
the FDA limits us, and also drug production limits us. The virus is produced by the NIH for us, and so it's not at the moment. It hasn't been stepped up to commercial grade. Once it becomes commercial grade and we can get a license, then obviously we would do more studies more broadly.
okay. Is either the polio or the CMV vaccine available on compassionate use yet?
Um, we have used both on compassionate basis on several patients in very special circumstances, but they're not available anywhere outside Duke.
Okay. I think that's about all the questions. Anybody else have any questions? Write them in now. Um, oh, what about using antivirals? Like Dr. Charles Cobb's in Seattle, he's been using an antiviral drug basically on the same premise that CMV is in most of the
Yeah.
glioblastoma cells.
So this is old data that used ganciclovir. It was in vogue probably about a decade ago, and there was some early excitement about it. But when larger studies were done, it didn't seem that the antiviral stuff helped. And I think that's because the antiviral drugs don't actually kill the tumor cell; they eradicate the virus. So the point of the immune vaccine is it's actually killing the cell that contains the virus. Is a distinction. The virus itself doesn't actually contribute to the tumor; it's just a passenger.
Um, for the CMV vaccine, do you have to test the patient to see if the tumor has the CMV, or a blood test or anything?
Yeah, we do a blood test. So most of the studies we've done have been on patients that are seropositive. We're looking at that at the moment because there is some evidence that you can have the CMV virus and not be seropositive. The early responses were mainly in patients that were seropositive to CMV. So that, in other words, they have circulating antibodies to CMV and evidence of past infection. We don't actually do a biopsy of the brain tumor. So we do blood levels for CMV.
Um, it seems there's some kind of controversy with the CMV brain tumor connection. Like you guys and Swedish Medical Center and some place in Europe say it's in almost every tumor,
Mm-hmm.
and yet other places are saying it's in almost no tumors. Can you explain what this is
Yeah,
about?
I think there is controversy. There's obvious controversy about it. So Dr. Sampson and Dwayne Mitchell down at Florida did the first, did really the bulk of the work looking at the protein levels in the tumor cells, and were very convinced. But it is a very difficult technique, and there's certainly other groups have not been able to replicate it on a regular basis. So, yeah, that's certainly right. There is some controversy about whether it's there or not.
You would think we could just get your pathologist and their pathologist together in the same room and fight it out.
Yeah, I think it's to do with the way you apply the antibody and you test for the protein. So it's not just a matter of looking down the microscope. And look, I mean, if I think we've got enough evidence to convince ourselves, and the FDA are convinced that there's a rationale to move forward. So the proof will be in the results at the end of it, really,
Sure.
and whether we can replicate it.
True. The results look very, very promising.
Right.
Let me see. Did you publish the results of that CMV vaccine?
Yes. Yeah, it's published in several places in different formats. So it was published in Nature in 2015, the senior author, John Sampson. It's also been published in Clinical Cancer Research. I'm not an author on that, so don't look up my name, look up John Sampson.
Okay. Oh, I got to just check to see if there's any questions on Facebook. Just give me 1 second. I'm sorry. I haven't been watching Facebook.
So I hope this was a good prelude to Game of Thrones.
I can't get into that thing on Facebook without messing up the stream. If anybody's watching from Facebook, please just text me or send the messages and we'll get back to you. I would say that's about all the questions we had. Oh, one last one just came in.
Okay.
Could you explain immune exhaustion? You mentioned it briefly, but just explain what it is and how it affects everything.
Yeah, so am I able to go back to the...
Yeah, we still have your presentation.
Oh, you do? Great.
Yes.
So when we talked about, can you see that, the slide I've just brought up, Al?
Yes.
Yep. So immune exhaustion really speaks to the adaptive immune system. And so what happens is the T cells, which are the very specific cells that hit identified targets, become exhausted if they keep trying to do their job and they're unable to do it in a functional or useful way. And so if I go back to this slide, exhaustion happens because the T cell gets stimulated in part through this trigger system called PD-L1 and PD-1. And if this PD-1 receptor is continually buzzed on the T cell goes to sleep or is exhausted. So the checkpoint inhibitors like nivolumab work by blocking this trigger here and waking the T cell up. And so that then is, rockets this into shape. The difficulty is that waking the T cell up only works if you've got a hot tumor. And that only works if the innate system's stimulated, in our view. So this is why you need this orchestrated response between the two parts of the immune system.
Okay. Another question. There's a couple other viruses around, like the measles and the Zika virus.
Yeah.
What is the difference between the three? Are they used the same basic way?
No. So each virus is very different. So the measles virus and the Zika virus have different capacity to induce inflammation and to get responses. One of the ideal things about the polio virus is that whilst it causes inflammation, it doesn't actually kill your immune cells. The measles virus and the Zika virus both will kill immune cells that come near it, basically. The Zika virus also hasn't got yet into a place where it's safe to use in humans. The measles virus, there's some early studies going on. There's also studies with herpes viruses, adenoviruses. So there is a lot of excitement. The herpes viruses are DNA viruses, and as opposed to poliovirus, which is an RNA virus. They're different, and they have different properties, and some will be successful and some won't. And I think it's early days, and we just have to wait and see what transpires.
Okay, that's about all the questions, and I thank you so much. It was very informative.
Great.
Just want to remind everybody we have a few of these webinars coming up. Just go to our website, virtualtrials.com, and click on the webinar and get the whole list. We have one every Sunday this month, and also Wednesday the 15th is a very special one. I'll send everybody emails and remind them. Thank you very much, and good night.
Good night, Al. Thank you.